Posterior urethral valves, or PUV, are obstructing membranous folds within the lumen of the posterior urethra. Posterior urethral valves is the most common cause of urinary tract obstruction, occurring in 1 to 4,000 to 8,000 pregnancies. PUV is also the most common cause of chronic renal disease due to urinary tract obstruction in children. Although not completely understood, the pathogenesis of posterior urethral valves appears to be due to a congenital posterior urethral membrane. In the developed world, approximately 1/3 to 1/2 of posterior urethral valve cases are identified by prenatal ultrasonography. Patients who are diagnosed postnatally usually present either as a newborn or young infant with urinary tract symptoms, abdominal distension, or associated clinical manifestations such as respiratory distress due to lung hypoplasia. In patients with posterior urethral valves, there are common renal and neurologic consequences, the first of which is chronic kidney disease. This occurs because patients may have renal dysplasia and/or acquired renal injury due to infection or ongoing issues with poor bladder function. About 15 to 20% of patients with PUV progress to end-stage renal disease. In some severe cases, the end-stage renal disease occurs early in infancy, and these infants may require renal replacement therapy in addition to medical management of the complications of renal failure. Vesico ureteral reflux, or VUR, is present in about 1/3 to 1/2 of patients with PUV. VUR is classified as secondary and is due to the increased intravesical pressure from bladder outlet obstruction, which results in failure of the normal closure of the ureteral vesical junction during voiding. VUR will resolve in at least 1/3 of patients with relief of the obstruction. Another common finding is bladder dysfunction. Bladder outlet obstruction results in muscular hypertrophy of the bladder wall and collagen deposition. These result in ultrasonographic and radiologic appearance of a thickened bladder wall. These bladder changes may lead to uninhibited bladder contractions or overactive bladder and non-compliance that may persist after relief of the obstruction. Because of the kidney issues, it is common for patients to have elevated serum creatinine and electrolyte disturbances such as hyperkalemia that need to be addressed in the neonatal period. A presumptive diagnosis is made by voiding cystourethrogram that demonstrates the hallmark findings of a dilated and elongated posterior urethra during the voiding phase. The diagnosis must be made in the absence of a urethral catheter, as the presence of the catheter may falsely give the impression of a dilated urethra. Based upon the VCUG findings, cystoscopy is performed to confirm the diagnosis. This allows direct visualization of the PUV. In addition to advances in surgical technique and instruments, primary ablation during cystoscopy is the preferred initial surgical treatment of PUV because it is a less invasive procedure that may preserve bladder function, and it decreases the need for subsequent surgical intervention. The ability to perform this procedure is determined by whether the size of the male urethra can accommodate the neonatal cystoscope. The timing of this procedure is dependent on the overall health status of the neonate and issues with general anesthesia. Although all patients with PUV are at risk for developing chronic kidney disease, patients with a persistently elevated creatinine after relief of their urinary obstructions, so they've had the PUV ablation, are at increased risk for end-stage renal disease. In addition, a significant number of patients will have persistent bladder dysfunction, vesico-ureteral reflux, and/or hydronephrosis, which in some cases may require clean intermittent catheterization and anticholinergic medications.